Hello, I'm Dr. Ira Nash. Welcome to Well Said. Today we're picking up a theme that we've touched on before, that is training future medical professionals to meet the needs of patients they will care for in the future. Specifically, we're shedding light on the diverse experiences of individuals living with disabilities. When it comes to truly understanding these experiences, it's vital to hear from those who live them and those who champion better solutions. That's why we're pleased to welcome our guest today. Dr. Adam Stein is the chairman and professor in the Department of Physical Medicine and Rehabilitation at the Zucker School of Medicine at Hofstra Northwell. Our next guest, Rebecca Colton, is an advocate for people with disabilities and a social media personality who has worked with Dr. Stein to educate medical professionals about the needs of that community. And our final guest for today, Michael Kalberer, is a New York State licensed social worker and the owner of his own motivational speaking company. Michael was recently on our show to talk about his remarkable experience as a research subject in an innovative gene therapy trial that helped restore some of his failing eyesight. I hope you'll go back and listen to that episode as well. So Adam, Rebecca, Michael, welcome to Well Said.
Good afternoon. Thank you.
Hi, thanks for having us.
Thank you all for being here today. I want to start with Rebecca and Michael. We're doing this audio only, so people who are listening to us can't see you. I described you both as patient advocates. Could you share a little bit about your own physical circumstances and how they affect the way you navigate the world? And we'll start, Rebecca, with you.
I am a quadriplegic, so I'm paralyzed from the neck down, and this was a result of a ski accident that I had 4 years ago on March 13th, 2021, when I was in college at Binghamton University. And so now I am in a power wheelchair and that I operate with a straw. So I blow into this straw and I could go forward, I suck and go backward, and that helps me get around. So that's sort of a picture that you can paint for yourself in your imagination of sort of what I look like, and I'm 25 years old.
And Michael?
I'm about 4'7" in a manual wheelchair, standard size manual wheelchair. I'm also blind from the LCA that was on the CRISPR episode previously. I kind of navigate the world with the assistance of people, either personal care aides or family or friends. Basically, the pursuit of dignified healthcare for people with disabilities became a passion project for me and a burgeoning career. As I went blind, I realized that communication patterns for me would change. People would start addressing the person accompanying me at appointments as opposed to me. I'll leave discussion of that for further questions.
Yeah. You have limited eyesight, but that's not your only physical disability.
I'm diagnosed with cerebral palsy of the spastic quadriplegic type, which basically means I get involuntary movements or spasms in all four of my limbs.
So we're going to turn to Dr. Stein in a minute to talk about the medical definition of what it means to be disabled, but I want to ask the two of you whether you have a personal definition of disability. And we'll start again with you, Rebecca.
I would say that to me it means that I'm inhibited in certain ways from being able to do things physically with my body because of my injury. There are ways that the world tries to accommodate me, but a lot of the times I am prevented from doing a lot of activities or going certain places because of my physical capabilities and limitations.
And Michael, do you have a sort of definition in your head of what it means to be disabled?
For me, disability is a medical construct as well as a sociological one. We can get into the medical minutiae of what it means to be a spastic quadriplegic and have a visual deficit caused by a lack of photoreceptor cells. My idea of transcending disability moves from a model of prevention, treatment, and cure of the limitations to a sociological one. I want to merge those two paradigms, if you will, merge those two theoretical frameworks into making healthcare or business relationships or mutually beneficial professional partnerships collaborative experiences. I do not want to be dictated to or have medical procedures administered to me. I want to work on behalf of providers like Dr. Stein and in collaboration with them to make the healthcare experience immersive, dignified, and collaborative.
Is that what you mean by the sociologic aspect of this?
Yes.
Okay. So, Adam, you've heard two articulate expressions of these folks about what their lived experience is like. Is there a medical definition of disability, and how does that align with what these folks have told us?
Yeah, years ago, the World Health Organization described disability as loss of a function that's expected for any person. Some disabilities include loss of ability to walk, feed oneself, get dressed, things like that. What I think you heard alluded to by Michael and Rebecca to some degree is the things that are unique to them. Those things that one loses that are unique to their particular functions in the World Health Organization would have called that a handicap. Those are the definitions.
Say a little bit more about that. Is there an official distinction between handicap and disability?
So the disability is the loss of a function that's expected for any person. Anything that's universally expected in a person as they grow and develop. If you don't have that, you have a disability.
Okay.
But the handicap is unique to that individual's circumstances.
So that could refer to the fact that they live in an inaccessible space, or I'm struggling a little bit to understand the distinction.
For Rebecca's sake, she was planning on actually going to medical school at one point. If she decided that she could not do that by virtue of her physical impairments, that would be a handicap.
I see. Okay. So look, there's a lot for us to talk about today, but I want to focus on what I think is a shared commitment that all three of you have, which is to training medical students and other health professionals to better equip them to deal with people with physical disabilities. I guess I want to start with a basic question, which is, I think our listeners may be surprised that this isn't already part of routine medical education. And I'll turn to Dr. Stein. Adam, if you want to just speak to kind of the history of this, and then we can talk more about what it looks like now.
Historically, disability-related education is underrepresented in medical education. We know that because as every medical student graduates from medical school, they're asked a couple of questions on their graduation questionnaire, whether they feel equipped to take care of people with disabilities. And that typically has not been answered in the affirmative over the years. So though medical education may appear, it is pretty clearly underrepresented in most medical school curricula, but improving.
Is there some overarching message that you would like to be able to deliver effectively to people who are training to be doctors? We'll talk about specific skills and other kinds of things. What's the top line message here?
That I'm not a set of symptoms, that I do not need to be cured as much as CRISPR has helped me, and that I would like to help the medical professional define what quality of life is for me and for other people living with disabilities, handicaps, or limitations. The differentiation between disability and handicap is an important one. It's an important distinction. Being visually handicapped as opposed to blind, there's an important distinction between the sociological construct and then the actual medical condition of blindness. The visual handicap can be overcome in a healthcare setting with a lot of narration. Okay, Michael, we're going to take blood from you. We noticed that you're spastic quadriplegic. Is there a particular side of your body that's looser today or may minimize the reflexes of your veins to roll back or you to jump when we stick the needle in to draw the blood? Through communication like that with my provider that is collaborative and person-centered, we can achieve the task.
What's your top-line message that you want to impart to physicians in training and medical professionals in general?
It's important to address your patient instead of the person that accompanied them, like Michael said earlier. It's always better to err on the side of addressing the patient, and if they are unable to answer you for whatever disability reason or whatever reason they have, then you can address their caretaker or whoever accompanied them. But it's always better to address them first, and then it's okay if they can't answer, but it's offensive to address their caretaker first, assuming that they can't answer and that they're unable of understanding the question. So I would say that's a very important message. And also I agree with what Michael said, that we're more than a set of symptoms. And what I like about Dr. Stein, who's been my doctor for so long, is that he tries to get to know me and not just my condition.
Well, I guess that's good advice for doctors in general, but seems particularly important in the context that we're talking about today. Given that that's the goal here, more collaborative care, somebody who understands you as a person, not just as a collection of symptoms or physical limitations. What specific skills or knowledge do you think that every medical professional should gain in their training to be better equipped to provide the care that you want to get?
I would say open-mindedness. What you're going to expect from your patient in terms of how they can respond to you, how they can communicate with you, with their voice, whether they use a device to communicate, whether it's through their caretaker who might maybe understand them better than you understanding them. So I would say definitely be open-minded and just willing to get to know them as a person and not be in like a rush to just do the assessment, take care of them, and whatever necessary medical needs you have to attend to, and then go on to your next appointment. So just like take your time with them and be open-minded, I would say.
If I can kind of paraphrase what you're saying, I think it's not just the technical skill, but humanity in dealing with you.
Yeah, definitely.
Michael?
There is an element of compassion that Rebecca spoke of very eloquently. There's an element of looking at the whole picture and us as people rather than just a set of conditions. Looking at me as a 47-year-old adult living with two disabilities, one acquired, one I was born with, I can give you insight into my expectations for the healthcare process as well. There should be treatment goals and expectations communicated to us, to individuals with disabilities and the population of about 46 million of us that live with them in America. And then we can decide whether or not to comply with treatment goals or the regimen of treatment. That is huge. People try to decide for me what my quality of life is going to be based on a set of what is their own biases, either unconscious or conscious, or stigma associated with both disabilities with which I live.
Yeah. So, Adam, you're the one here who actually has formal responsibility for teaching medical students and imparting some of these training paradigms. How do you approach this? What are you trying to teach medical students about care for this community?
There's an awful lot. I want to actually begin to answer that by citing an important study that was published 4 years ago, actually published by a disabled physician named Lisa Iazzoni.
Somebody who I graduated medical school with.
Is that right?
Yes.
Dr. Iazzoni granted anonymity to over 700 physicians who then gave their opinions on what it's like to deliver health care to people with disabilities. And what she found was really illuminating. She found that over 80% of those physicians felt that people with disabilities have a worse quality of life than their able-bodied counterparts. So just that alone makes it easy to understand how a physician may deliver biased care toward that individual. Some other things she noted were that only 40% of those physicians were confident in their ability to take care of people with disabilities. So that meant obviously 60%
So meaning
were
they
not.
didn't have whatever specialized technical skill they needed to deal with problems that may be unique or more prevalent in this community.
Technical skills and training. To top that off, about 55% only welcome people with disability to their practices. So that, of course, means that 45% didn't want them in their practices.
And why would that be? You and I probably could come up with the answers based on our own experience. What are the reasons behind that number? I hope that's a little shocking to people.
Yeah, I hope so. I think there are several. I think one is the perception that they will make their practice fall behind.
Takes more time to deal with these folks.
That's one.
Okay.
And I think one is their own discomfort. I think they are hesitant to take care of people with disabilities because they're not sure how to themselves. So I think maybe those are the main two reasons.
Rebecca and Michael, has that been your experience in dealing with physicians and other medical professionals that you've come across in your journey?
There is not malice, but there's reluctance to deal with us. There's reluctance to ask the questions that need to be asked of, hey, Mike, we want to draw blood from you. We need to draw blood from you for this purpose as part of a physical examination, check some levels of your cholesterol and things like that. We know we need to, but how do we do it? So I'll just say, okay, this is how we do it. Use either a 21 gauge needle or smaller, maybe a baby needle. You can go to the veins in the crook of my elbow on either side of my arm. If you want to go into my hands, we need to warm up my hands a little bit. We can use a rock salt or a hot pack, or even run my hands under warm water and then have me clinch and make a fist on a stress ball or something like that to get the blood flowing down through my extremities, and then we can get it done. But there is a reluctance, and there's also perhaps a fear of liability, perhaps a fear of the physical environment of the office not being accessible enough.
Yeah.
Perhaps a fear of ADA noncompliance, which leads to what I call attitudinal noncompliance, or the apprehension Dr. Stein spoke of. For me, compliance is not just a legal construct, it's a concept of attitude.
Right. Okay. Rebecca?
I haven't really had any experience with a doctor not taking me on as a patient because of my disability, but I would or like any really negative experience. But I've also been injured just 4 years versus like being injured longer than that or being born with a disability. But I also will say like I'm less likely to go see a doctor that maybe I do need to see more frequently because it's harder for me to get around or it's harder to find an accessible office. Like for example, if I need like a full body check at the dermatologist, like I haven't gotten that done because I don't know how they would necessarily do that because I'm connected to this large chair.
So Adam, let's circle back to you again. As somebody deeply committed to improving the education of students around the care of people with disabilities, what techniques have you used or found to be effective in lowering these kinds of barriers that we've been talking about?
I'm very fortunate to be able to work at the Zucker School of Medicine, which has been very open to including this in the curriculum. And so we do a session every year that really involves practice. The students are in small groups. They each have in their small group a person with a disability. We set up a situation where they're pretending to interview someone who's presenting as a new patient for primary care. We have teaching points, obviously related to communication, that I think Rebecca and Michael have discussed earlier. For example, not speaking to the caregiver, speaking to the person. We run through a series of what is called a review of systems, as you know, which is just making sure that we hit all the areas that are likely to be affected by a person's disability.
That might be specific to somebody with a particular kind of disability.
Yes.
Okay.
So want to make sure that someone like Rebecca gets asked about her breathing and gets asked about her bladder function and her bowel function. That's actually for our second-year students. All our third-year students have a week of experience with people with disabilities. In that week, we teach them a basic mobility assessment to teach them how to assess function, cognitive assessment, and refine their ability to do muscle strength assessments.
So some technical skills that are specific to the assessment of people with physical disabilities. What I heard from Rebecca and Michael both was this sense of trying to develop a deeper sense of respect, really, empathy, respect for autonomy in patients with disabilities. I'd like all three of you to comment on how you think that piece of this gets effectively imparted to trainees. And Adam, maybe we'll start with you again.
Yeah, I think the construct and the setup that we use for our second-year students is the most effective way to do that. What we do is we have actual patients play the role of themselves presenting for a new.
So nothing like practice is what you're saying.
But nothing like practice on the real thing.
Yeah.
Yes.
Okay.
As opposed to a faculty member playing the role or hearing a lecture about how to do it.
Yeah.
They're actually doing it on the person who's affected. And that almost always creates a connection, and that connection is what we're looking for, because that connection leads to trust. Trust leads to coming back and good health care.
Yeah. I'm curious to get the reaction of Rebecca and Michael to your comments.
For those of you who cannot see me, I had a huge smile on my face as Dr. Stein was speaking about what he just spoke about. I am in the process of writing curriculum that improves these practical examinations of individuals with disabilities to not only include the communication etiquette and the initial development of those career-based skills, but to continue to monitor and assess their growth and progress. Part of the underrepresentation of individuals with disabilities that Dr. Stein spoke of earlier in the medical profession and the medical curriculum comes from, and perhaps part of the apprehension comes from, a generalization that individuals who study cerebral palsy or neurological movement disorders, neuromuscular movement disorders, may study the worst cases on a continuum of those. So a lot of times people think my disability is cognitive or accompanied by epilepsy, when it, in my case, fortunately, is not. So a lot of the communication come initially with me and for me, and I don't want to speak for Rebecca, but I'm pretty sure Rebecca has experienced something similar to this as well, comes from a standpoint of deficit or not knowing, and creates what I call eggshell syndrome, where the provider is trying to do the exact right thing but winds up inadvertently doing the exact wrong thing by talking to the person who accompanies me.
Yeah.
Recently, and Dr. Stein, you can correct me if I'm wrong, the life expectancy of people with cerebral palsy, with or without epilepsy, particularly in males, has matched the life expectancy of my able-bodied counterparts. So that means diagnostic and assessment testing is getting better, as well as our ability to advocate for continued consistent healthcare on an ongoing basis. For me, assessment of my spasms can differ. Any given day, one side of my body can be more spastic than the other one. So just to be able to collaborate with a doctor on that and say, hey, we got to do an EKG today. I can't get on the exam table. Are we able to do this in the chair? And show them how to tape the leads and do it in the chair is conducive to success. There is no cookie cutter template, but I'm happy to see that Zucker School of Medicine is leading the establishment of what I would call standard of care or scope of practice for future medical professionals, and I hope to continue to be at the forefront of advocacy for that.
Rebecca?
Yeah, I agree with what Dr. Stein said. When the students deal directly with the patient with disabilities, and it's not an actor, it's not reading in a textbook, it's not a slideshow, but they're learning about them as a person and also about their medical condition as a whole. So it's the two that come together. I think that's really going to help them understand that there's a person behind this set of symptoms in this condition, and talking to them directly and learning that, yeah, every disability is different. Even though we might both have a spinal cord injury at the same level, we could still have different capabilities and different things need to be assessed. So I think that's really important to be dealing with them in the real world instead of just reading about it. I think that should be implemented at all medical schools, and I don't know which ones do it and which ones don't. And I've done this event at Hofstra 3 years now, and it's been wonderful, and I think the students benefit a lot from it.
Do you have any stories that you could share about maybe the impact of those interactions that you've had with students?
Well, I know that they get very good feedback on the event every year, and there is like a lecture part that comes before it that's super informative, and I always leave and learn something every year about, people with disabilities and their experience in the healthcare field. And I would just say that I don't know if I have any specific stories, but I just know that people benefit a lot from it, and I enjoy it a lot. I feel like I do connect with the students. I mean, it also does help that I'm close to their age,
I was going to say,
I actually interviewed for Hofstra Medical School, so it's a bit ironic that I'm now there, but for a different reason.
You're on the faculty instead of
I'm on the other end.
instead of a student.
In another world, I could have been one of those students interviewing someone else in my shoes, and so I do think that that's a bit ironic, and I do feel like I connect with them, like I said, maybe because of a similar age, and I do speak about my social media experience, and I tell them to look me up, and they do, and they say they think I'm, funny, or they enjoy what I post, so I like going and connecting with them.
As long as you're talking about social media, we should give you an opportunity to plug your social media presence. So tell us how to find you on social media.
Sure. So on TikTok, my username is not paralyzed, just lazy. That's one word. On Instagram, you would have to search my name, which is Rebecca Colton, Koltun, and I just post funny videos, sometimes informative videos, sometimes both. Life with a disability on Long Island, and just how I go about my life and do things in a different way now. And I really enjoy sharing that with the world.
I want to ask you all one other sort of very practical question, because it came up earlier in our conversation about physical accessibility to healthcare environments. Is there one particular thing that you could suggest or identify as a critical barrier to access that you'd like to see us as medical professionals do better with?
Height adjustable exam
Adjustable
table.
exam table. So meaning one that's motorized and can go up and down.
Yes.
Make it easier for you to get on, easier for the doctor to examine you.
Yes, and for the love of God, wheelchair accessible scales.
Wheelchair accessible scales.
So I can get weighed during a physical without having to go to a bariatric floor.
All right.
They cost about $800 on average. If you see 2 patients a month at standard Medicaid rates, it will eventually pay for itself because the patient will come back.
Yeah.
And I don't mean to overstate that.
Adam, anything you want to add to that?
Very recently, actually became a federal standard that any practice that is receiving federal funds and treats people who are covered by federal insurances have to have accessible scales and an exam table. So that's now not optional. One other thing that we have in our offices are sliding boards. A board that a patient can slide along makes it easier to get them onto an exam table. And one thing that I particularly glad that I have in the office, so it's not unusual, maybe unusual for a physician like me, is we offer phlebotomy. So we need to get blood tests. It's one-stop shopping. Patient with a disability then doesn't have to make a second stop on their way.
Which might be burdensome. Yeah, Rebecca?
I would say, as the only woman here, it would be important for me to be able to go to the gynecologist and be able to get an exam without having to get onto the exam table. I feel like that is something that could definitely be possible. And when I did go, I did have to get on the exam table, and that was a process because it's you need 2 people to lift me, and then we have to make sure I don't fall off because there's no side rails. So there should be a better way about it.
I hate to sort of end this conversation because I feel like there's a lot of rich stuff for us to talk about. Just in the interest of time, we're going to have to wrap this up. And I guess I want to ask each of you one last question, which is looking forward, meaning into the future, what's your hope for the education of medical professionals and in the care of patients with physical disabilities? What would you like to see different going forward?
My hope is to see that other institutions that teach higher learning, particularly those affiliated with teaching hospitals and or children's hospitals like Zucker is with Northwell, continue to establish not only a standard of care, but a way to measure progress and compliance with that care. And my hope is not only to give it lip service, but be at the forefront of changing the medical model from one of symptom alleviation, treatment, and cure to sustenance of the quality of life that the individual decides what is quality for them and does so collaboratively with their physicians or primary care physicians or eye doctors or whoever the healthcare provider is.
I'm going to make a slight editorial comment that would be good for all patients, not just patients with disabilities.
Right, let's universalize it.
But I think that's a great message. Yeah. Rebecca?
Yeah, I think it would be important to put just as much weight on the education of dealing with patients with disabilities as other topics so that when students graduate, they feel just as comfortable speaking with the patient with disabilities as an able-bodied patient. I think that would be a step in the right direction.
All right, Adam, as our medical educator professional, you get the last word here.
I would give the same answer. Just keep increasing penetration of disability curriculum into its medical education.
Yeah. Okay. I want to thank all three of you very much for joining me today. I think it's been an illuminating conversation about an important topic, and I want to thank all three of you for your advocacy in this space. My guests have been Dr. Adam Stein, Rebecca Colton, and Michael Kalberer. Thanks also to our editor, Edward Lee, our producer, Conor Pilkington, and our audio engineer, John Mullen. For more information about this particular program and to find all of our past episodes, please visit our website at medicine.hofstra.edu/wellsaid. You can also subscribe to our free podcast wherever you get your podcasts. Our listeners are also welcome to send their comments, suggestions, and questions to wellsaid@hofstra.edu. Until next time, I'm Dr. Ira Nash, and that's Well Said.